testimony from Dr. Ramona Coelho.
Thank you. I'm a family physician, a senior fellow at the MacDonald-Laurie Institute, and an adjunct research professor at Western University. I served on Ontario's MAID Death Review Committee and have published extensively on MAID, but I speak in an individual capacity today. For 20 years, I have cared for patients with complex disabilities, mental illness, chronic pain, and extreme social vulnerability, so people who live in poverty and other forms of marginalization, men out of prison, refugees. Suffering is complex and different for everyone, and it's shaped by psychological distress, trauma, poverty, isolation, and lack of supports. And addressing this takes careful assessment and time. And community life also plays a major factor in mitigating suffering. Yet, in Canada, some individuals do receive MAID when suffering is driven by these unmet needs. In my practice, I have observed and spoken about troubling patterns of how MAID was introduced and assessed. Some patients were referred immediately after a new diagnosis by a specialist. Others were approached repeatedly during vulnerable hospitalizations. I've brought patients onto the BBC to speak about that. And some were assessed and approved quickly without meaningful exploration of suffering or supports in place. Ontario's MAID Death Review Committee reports they contain anonymized cases, but they are real, and you should have them all. Across these cases, there were individuals with untreated mental illness, suicidality, addiction, isolation, and unmet social needs. And they demonstrate premature eligibility, inadequate safeguards, and a failure to address suffering before ending lives. So I just like to say that it's not fair to say that all cases in the media are fake. That's gaslighting the disability community and their stories. We would never do that to people who want MAID. And we can't fool ourselves that all MAID providers get it right every time. The MAID Death Review Committee cases exist. And in particular, the stats from the MAID Death Review Committees reveal that Track 2 cases reflect high social vulnerability and untreated mental illness. Statistics show that nearly 30% of the patients lived in poverty. More were women. Many listed a lawyer, physician, or a friend. They couldn't list a family member as their next of kin, suggesting a high level of social isolation. Less than half of these people before they died received mental health or disability supports, and less than 10% received community solutions or income. These are the major solutions my patients need to thrive. So although framed as choice, MAID can allow structural coercive influences to push people towards death. With mental illness, it is not possible to reliably determine that someone will not recover. At the same time, many Canadians wait a long time for specialized psychiatric care, and that prolongs recovery and increases suffering. Suicidality, lack of insight, and impaired judgment are symptoms of many psychiatric diseases, and they fluctuate, but recovery is possible the vast majority of the time with or without treatment. Given the lack of evidence to guide MAID assessments for mental illness, like for my patients, bias and discrimination will inevitably determine who gets MAID and who gets suicide prevention. I invite you to read my article, Discrimination-Driven Deaths, Analyzing Ontario's Coroner Reports on Euthanasia and Assisted Suicide. In response to claims made here that MAID professionals consistently follow guidelines and that CAMAC guidance doesn't have any problems, I do really urge you to read these reports. And you can read my article. Also, consider the risks of expanding MAID on suicide contagion. MAID presents death as a solution to suffering and provides the means to achieve it with clinician support. One witness cited here that a documentary on MAID for mental illness, she noted that the individuals committed suicide when the delay was announced and said that that contributed to their deaths. But why might this have occurred? Repeated exposure to messaging from both the government that this could be a solution to their suffering and being followed around, framing their lives that it would be dignified to let them die, can increase the resolve to end one's life and can actually worsen suicidality. We know this from suicide prevention research. Further, the CPA's consensus statement on MAID for mental illness is opinion. It doesn't add anything to this discussion on evidence-based medicine. It should not reassure us that we are ready to proceed, nor guide life and death decisions, even on a case-by-case basis. In contrast, the International Association of Suicide Prevention in December of 2025 states that MAID should not be provided for mental illness solely, and that suicide prevention principles must apply to all people, including those with disabilities and those at the end of their life.
Okay, thank you, Dr. Coelho.
Oh, okay.
Yes. Maybe 5 seconds to wrap up?
Just one line,
Okay,
actually.
one line.
The
Go
UN
ahead.
Committee on the Rights of Persons with Disabilities has advised on repealing Track 2 MAID and stopping the expansion for MAID for mental illness. Thank you
Okay,
very
thank
much.
you. I should have forewarned you, but
That's okay.
so we will now have a final